Good afternoon. So we are live. For anyone who's here, my name is Alex, and we are going to go through some clinical vignettes for step 2CK. You can leave your name in the chat box in order to have an interactive course. Now, one of the typical questions on 2CK is on the atherosclerotic cardiovascular disease risk. Practically, the vignette will ask when to prescribe statins. All in all, there are 4 indications for statin prescription. Firstly, we will have a presentation of a patient that comes with hyperosmolar state due to his diabetes. He will also be over 40. This requires a high potency or a medium potency statin. However, there might be some clinical vignettes where there is the case of a 21-year-old or a 20-year-old who presents with DKA, and they might ask you if he needs or not statin. He does not need any statins as he is well below 40. The other case is when we have an atherosclerotic cardiovascular disease of more than 7.5% and when he is more than 40. Now, you will not calculate in 2CK the risk. However, the more cardiovascular disease risk factors the patient has, the higher is the ASCVD. So if we have a smoker that presents also with a history of coronary artery disease or carotid artery disease, and whose LDLs are managed poorly, then we can go already for the statin prescription. There's also the typical case when the patient comes with a stroke or an MI. In this case, they are always prescribed statins. Lastly is when the patient has familial dyslipidemia and he's more than 21, then we can also prescribe statins. The history of familial dyslipidemia can be mentioned as an early myocardial infarction in the family, but it can also be found as an acute pancreatitis in the father or mother. Okay. Let me know in the chat if there's any question. Otherwise, we'll go to the other type of clinical vignettes that is tested frequently, the cardiovascular category of 2CK. Another question is on how to treat AV blocks. You will have a patient whose EKG will be displayed. Then the question would be, what is the best next step? Now, if the patient has type 1 or type 2 Mobitz 1 AV block, then we will just observe. If the patient has Mobitz type 2 or type 3 AV block, then he has an indication for pacemaker. Let's recap a little bit the definitions of each AV block. An AV block type 1 means that the PR period is greater than 200 milliseconds. Type 2 Mobitz 1 is characterized by prolongation of the PR segment until the P wave is dropped. By contrast, in type 2 Mobitz 2, we have one P wave that is dropped without prolongation. In type 3, we have altogether QRS, which is independent of the P waves. Another case is the case of the elderly, which come with severe bradycardia that will go into tachycardia. This case of bradycardia tachycardia is also known as sick sinus syndrome. It also benefits from a pacemaker. Hello, Lucas. Okay. The next topic is represented by unstable angina and non-STEMI. At 2CK, there's an usual trick about ACS. Patients will be presented in such a fashion that you will consider it an acute chest syndrome, but you might think that it's myocardial infarction type STEMI. The vignette will come with a patient that has chest pain, that is dyspneic, that has pain that radiates to the jaw, to the neck, to the thumb. He will have diaphoresis. He might also had suffered syncope. You will already think of myocardial infarction. However, you will have as answers what is the best next step in this case. And the answers would be something like give aspirin, give beta blockers, take him to the catheter lab, or give him heparin. Now, in order to narrow down from acute chest syndrome to unstable angina or non-STEMI, and to differentiate from STEMI, you have to take a look at the labs that they will give you. The troponin will be normal, and if you have an EKG, you won't see ST elevation, but rather an ST depression and T-wave inversion sometimes. A tricky finding would be an ST depression that would be just a mirror for V1 and V2 in the case of RCA occlusion. Now, the correct answer in this case is that you think of ultrasound or non-STEMI and you go for the heparin or some low molecular weight heparin such as enoxaparin. Okay, are there any questions on this type of material? Let's go to another cardiovascular question that might be present at 2CK. Namely, at 2CK there are two important facts that are tested for abdominal aortic aneurysms. Firstly, what are the conditions for screening? This means you will have a patient that is 65 years or older, and also he has a history of smoking. These two components, having a history of smoking and being older than 65 years, are an indication for having an ultrasound of the abdomen to screen for AAA. If the patient already had the ultrasound, then he has no longer an indication for screening. The ultrasound is given only once. In regards to the other fact tested for AAA, namely the treatment, we can treat it if the diameter is greater than 5.5 centimeter or if it is rapidly expanding. Otherwise, we use only ultrasound surveillance up until it crosses the 5.5 threshold, when we can intervene surgically. Please let me know if you have any questions on the topic. Okay. Now, let's go for the side effects of anticoagulants. These are these are drugs tested usually at step 2CK. Now, firstly, for the heparin, the question that is frequently seen is, what is the best next step for HIT type 2? You will be given the choice of administering protamine sulfate, which actually is the antidote for heparin. You will be given the choice to do a platelet transfusion, and you will be given the choice to discontinue the heparin. The correct answer is to discontinue the heparin, as the other ones are in severe cases after the patient was discontinued from heparin. So after he was discontinued from heparin, we can consider the dabigatran switch. Doing a platelet transfusion will only lead to further destruction of platelets, and administering protamine sulfate is not appropriate in this context. The next anticoagulant that is tested on 2CK is warfarin. Warfarin will present with the necrotic skin lesion due to the protein C and protein S short half-lives. Therefore, there is a propensity for coagulation at the beginning of warfarin treatment. To treat this necrotic skin lesion, we have firstly to again discontinue, but not heparin, but warfarin this time. If you will have one choice that will suggest to administer fresh frozen plasma, then you would have to opt for the discontinuation of warfarin. Okay. Lastly, usually patients with atrial fibrillation and ischemic strokes will require, as a first step, when the question is prompted, what is the first step in this patient with an ischemic stroke with a history of atrial fibrillation, or maybe you're given an EKG that shows the irregular rhythm, then the first step is not to administer thrombolytics for that case of ischemic stroke, but to administer warfarin or heparin. Okay, this is everything for today. Let me know if you have any questions cardiovascular related to step 2 CK. Okay, then I'm grateful for your presence, and I wish you well until next time.